Thank you for staying with us. The Africa Center for Disease Control and Prevention has stated that only one country in Africa is adequately prepared to respond to public health emergencies. Nairametrics reports that the Director-General of Africa CDC, Dr. Jean Kaseya, conveyed this concerning information during a side event unveiling a 5-year strategic plan aimed at strengthening public health emergency operations centers in Africa and the Eastern Mediterranean region. Dr. Kaseya identified South Africa as the sole African nation currently ready to respond to public health emergencies. He urged other member states to accelerate measures and mechanisms to enhance their responses, emphasizing that the lack of preparedness in other countries puts the entire African region at risk of outbreaks. Let's look at this. I'm joined by the Medical Director, Chidicon Medical and Diagnostic Center Limited, Njemanze. Doctor, thanks for sharing your time with us on One Slot.
Thank you for having me.
All right, I guess we'll start with your initial reaction to the announcement that only South Africa is prepared to respond to public health emergencies. Were you surprised?
Not really. I'm not surprised. And with reference to Nigeria, it's not a surprise. We've been saying this for several years, that the health architecture itself is faulty. Nigeria being the biggest country in Africa, we have a health architecture and the structure of the health system is totally faulty. In any health sector, the health sector stands on a tripod design. So the infrastructure and everything is built on a tripod. The first part of that is research. Every healthcare sector must have a research arm, and that is called the national, like in the United States, you have the National Institutes of Health. In that research carries out research in a broad spectrum of places. They issue grants, and these national research institutes are based on finding out what will be the next disease, what will be the next public health problem. And then they do investigations, give grants to investigators in different institutions, both private and public. And this will actually put the topic of whatever is coming up in the scientific community. Now, the second arm is the treatment arm, which is what we have. Basically have a network of hospitals that treat people when they are sick. And the other one is now the preventive arm, which works like a Centers for Disease Control. What we have, yes, we do now have a Centers for Disease Control, but it's not really designed for real disease prevention. You must have the healthcare stratified. At the local government level, you must have a Surgeon General. At the state level, you must have a Surgeon General. At the national level, you must have a Surgeon General. Actually, post-colonially, we even had a structure that seemed like as if it was well-designed. You had sanitary officers. You had people who were health inspectors. All that is almost absent now. So the design of the health sector is actually faulty from its foundation. So it will be a miracle if the system now can answer to anything, not to even talk about an emergency. So it's not a surprise.
Right.
But the second arm of the problem is...
Okay.
Yeah, go ahead, please.
No, complete your thoughts, sir.
Yeah, go ahead, please.
No, I think you will go ahead and complete your thought.
Okay, yes. Yeah, what I was saying, the second arm is, which is not a welcome development, is if you take an institution like the WHO, it was designed to work from the ground up. That means at the country level, the diseases or the health challenges are discovered, even to the point of their solution. And now it is brought to the international level. And there, at the international level, then you try to exchange experiences, and actually come up with some consensus on how to deal with this. The unwelcome development now, especially vis-a-vis the WHO, is they are now designing a top-down approach. That means they make all the decisions in Geneva and then to tell us what to do. And this is totally unwelcome and unhealthy for the health system. Let me tell you one or two things that
but that bottom, how would that bottom-up approach work really? Because there will be so many layers to, address before you come to make a decision. And some would say sometimes it's better to, make research from a couple of persons, try out a method. If it's not working, you find out why it's not working and implement. Wouldn't that be a more effective way to, look for better solutions?
Let me give you just a practical example. In Nigeria, way back from the 70s to the 80s, and when we knew Ransom Kuti was minister, he came up with a very simple idea of hand washing and then bringing sanitation to the schools. And then this solution he brought in order to lower infant and child mortality. It was so effective that it lowered our infant and child mortality drastically. Now, this was brought to the center, and of course, it took time for WHO to fall in line with that. But when they fell in line and actually started supporting the programs, it was incredibly very successful. Let us take the solution in Uganda during the AIDS epidemic. The AIDS epidemic was running up to 30-something%. What happened? The Ugandans said, well, wait a minute, abstinence is a valid way of doing this. And let us now project abstinence. They did that. What happened? The disease prevalence crashed from 30-something to only about 6%. It was drastic. This was discovered locally. So the whole miracle, I would say, of transformational changes that are happening in the health came from a bottom-up approach, not from a top-down approach. It's a disaster. Even with the recent COVID vaccination and blanket orders that people should be vaccinated and all that, it didn't so work well at the country levels. And of course, it did not do so much good for Nigeria and other countries.
There was a question I was going to ask you, but you've sort of answered it already. What are some of the key factors? But let's get key factors that contribute to a country's level of preparedness in responding to public health emergencies. But I'd like you to right now explain the criteria used to assess a country's level of preparedness. South Africa, for instance, how did they become the only country in the whole of Africa that is able to respond to public health?
Now, you look at the ratios of the medical personnel to the population. There was the ratio is, you look at the bed space, you look at the resilience of the health system in terms of units to monitor disease prevalence and surveillance. So it's a whole complex collection of data. But if you apply this criteria to across the board the countries in Nigeria, it will be very difficult to have us qualify for that purpose. However, the error in using that in Nigeria and some of the countries, it's only a small percentage of our people who believe relatively in Western medicine. Okay, so if you're assessing that using the criteria to assess healthcare availability in Nigeria, you might be mistaken, because many people will tell you for most things they use faith-based approaches. Some of them use traditional approaches. These people are not going to come to the hospital, neither will they need bed space in the hospital, neither will they need doctors or nurses for disease prevalence. They manage with their local means. So when you have such a complex system, what is being referred to when they say the availability of healthcare, they are only judging what is available with Western-based medicine. But that's not the case in Nigeria. In so many communities, we have the traditional medicine structure, which is very much prevalent. Most people in these traditional communities don't even take medicines. They take herbs or some other remedies. So that assessment has to be done very carefully with the understanding that you cannot use the strict Western criteria to judge the availability of care in Africa and in Nigeria.
Well, shouldn't there be some basic baseline that you can use, really? Because when you talk about Africans, resorting to other means of care as against the Western option, we still need to study how this works. People in your profession always advise caution when using the traditional method of care when you have an ailment. So shouldn't there be a baseline, really?
Yeah, there should be. And we have been talking about this for ages. What some of the countries, even some of the countries I know in Tanzania and a few other countries, well, they have stratified and tried to actually build a structure into the traditional structure. So that means they have a systematized diagnosis, they have medicine provision, issues of toxicity are being studied in some places. China did exactly the same thing. And what did China result to? Most of the revolutionary medicines we use today that have significant health impact is from China. Where did it come from in China? From their traditional medicine. Guess what? You and I still use artemether. Where did that come from? From the traditional Chinese medicine. Could we do the same thing today in Nigeria? Very much so, and maybe more successfully than even China. The problem we have bought into, and I would say a lie we have bought into, is to emphasize that we can only get what makes sense through the Western structure. And this is very wrong. And as a scientist, and as a medical scientist, I believe strongly that we should be looking into our traditional structure and how the positive things we can derive from it, how we can systematize that. What is that systematization? We should have a traditional pharmacopoeia. Pharmacopoeia, there you write all the herbs and the drugs, which one is used for what, in what preparation dose, and what the toxicities might be, what are the precautions. We should have a national pharmacopoeia on traditional medicine. Up till now, Nigeria doesn't have any. So this is the problem, and you cannot get that if you don't have a research arm whereby we bring in the traditional knowledge and then use this knowledge in order to work it out so that we can have a conventional system which people can access. And this is due to the, I think, colonial mental framework which we are working on in this country and even across Africa, that everything Western is of great value and we don't need to question that. That is very wrong. And countries that have chosen the alternative way of doing things have become revolutionary. Let's take, for example, China. Look at what the traditional medicine in China has done. It has transformed their medicine and actually has transformed the world, because without artemether or AZT, the drugs made from it, we wouldn't have any remedy.
All right. While I get what you're saying, the point you're making, Doctor, when I talk about the baseline, it's not in Western about figures, calculation, you know, all those necessary yardsticks that's needed to actually assess the viability of options that, and you've said it yourself, there is more work needed in the traditional health sector. So we're almost out of time, but I want you to speak quickly on the reason that gave rise to this conversation, and that's the submission by the Director-General of Africa CDC, Dr. Kaseya. He talked about the crucial role of having robust public health emergency operation centers in preventing and responding to outbreaks. So before we discuss their plans, tell us about the centers that he's talking about and why they are important.
Yeah, I think the main emphasis is on surveillance. Surveillance means a system whereby you can detect something happened here and then that is of interest. So, and how that normally happens at the local level is that all of a sudden there's an outbreak of a disease and people are showing up somewhere, and then the health workers around go and then find these cases and take them from there to maybe the local government hospital there, and then from there it is referred further to a more sophisticated tertiary center in which then the questions are being asked. What is this? Is this the pneumonia we know? What is atypical about this? So the surveillance system, that means the system for detection of an unusual occurring event is what is primary to this. And you can't do that without a properly designed preventive health arm. It's not possible. You really need people, a structure on ground. You really need that local government or ward surgeon general who will see this and say, wait a minute, this is very unusual. This is not our usual pneumonia, but let me send it forward to the tertiary care center for further investigation. So that is what is lacking today in a structured manner. And it's not that it's difficult to do, it's just that there has been lack of political will to do this. And this is one of the most important duties of government. Healthcare is the foundation. If you can't take care of the health of the people, then really, what can you actually give them politically? So I think it's a failure of the structure. And the structure that is failing is that preventive arm.
All right, we're almost out of time, so I need to ask you this one. It's important. How can African nations really collaborate? There's so much ideas, so much, innovation, localized in different parts of Africa. How can we collaborate and learn from one another's experience in responding to public health emergencies?
Yes, I think the most important thing is that, it's good you mentioned the African CDC. We should have a real structure. What you have now is just an agency that announces numbers really without any structure to support it. So we should really have a well-designed Africa level Centers for Disease Control for preventive arm, then of course the country level, and then of course the local government level, and then the ward level. So it has to be a whole functional structure rather than just be a collection of people who announce numbers from here. It really doesn't help. Structurally, by name is there, but in real, there is really no structure supporting it.
All right, quickly in 30 seconds, if you can. I'm told we have less than 2 minutes. Looking towards the future, what do you see as the most urgent priorities for improving African countries' preparedness for public health emergencies?
Yes, there has to be a major health summit in which the whole African countries will gather and then decide to make sure that they properly design their health system. You have to put the research arm, you have to put the therapeutic arm, and then the preventive arm. This tripod is inevitable in any country, no matter where you take it from. And African countries have to do the same.
Dr. Njemanze, thank you so much for your contributions on the program. We appreciate your time.
Thank you for having me.